Indian. And if you are in a group that is not white in Minnesota, we have some of the worst outcomes, or we have some of the greatest differences between people who are thriving and people who are not. Next slide. So in order to really, look at that pattern more, then also one of the statistics that actually pulled me into this work initially was the infant mortality. Our infant mortality is more than twice as high for people, African American and American Indians, than it is for whites. But that statistic is really just one of all the disparities that we see in every single condition. Just about every condition, we see the same pattern. So that's why I'm bringing up that pattern. Knowing and looking at the pattern and recognizing it as a pattern is an important use of the way we can look at and use our metrics. Next slide. So when we're looking at these patterns, in order to dive in further, we have to disaggregate the data by race, ethnicity, language, and we have to really pay attention to that, because we saw improvements, or what looked to be improvements, in our African American infant mortality until we disaggregated African born from African American, and we saw that actually, once again, the averaging was making it, the African-born babies, parents who had babies were actually doing better than our African-American, which that number had not improved. So it's important to disaggregate the data. We've seen the same thing with Asia Pacific Islanders. We have a large Hmong population, and I believe there's one group in the States of Solution who disaggregated the data and was able to see that the Hmong population was not thriving the same as other parts of the Asian Pacific Islander population in terms of breastfeeding, for example. But so so the first thing is to actually look for those patterns so we can see who is and is not thriving. And then the second part of this point on this slide is that we have to also begin to look at this data by the social determinants of health. And those are really start to connect who's thriving by who has food security, what is the outcome of health outcomes by income, what are the health outcomes, and connecting the paid leave, who has and does not have paid leave, and then whose children are doing better. We know that people with paid leave, for example, their children are immunized more than the people who do not have paid leave. So we start to connect the dots with the social determinants of health. Next slide. Next. And then we begin to look at what parts of our population are experiencing these health inequities. And when we use the word health inequity, those are the things that are actually, it's not just the difference, but it is the difference that's connected to the opportunity path. So again, the difference that you can walk back, like we have, what's the difference between people employed and people who are not employed? Who are they? Who are in these populations by race, ethnicity, and language? And then what are the health outcomes that are correlated to that? So that's an important sort of shift that we went through in our story. Next slide. When we, so the difference in the kinds of questions are, it's not just descriptive. It's not just like who has what obesity rate and what groups have higher rates of obesity and stopping. We also then say why. What are the conditions that create the difference in obesity between populations? And then through that why, we start to identify what those conditions are that we can have an impact on and change policy. So this is where the qualitative data and the relationship become really important, not just to inform ourselves and our work, but it also is very energizing, and or it strengthens the community's ability to tell their own story when we are in relationship and connect the dots in this way. And I have, next slide. So when we start to look at the overall pattern, we see that the disparities in health are actually completely connected to disparities in opportunities and in societal disparities. And I'm going to go back to that word, social determinants of health, because these are socially determined opportunities. These are determined through policies and investments and decisions. These are human-made differences. And next slide. So we actually can say this definitively, that our disparities are not simply because of a lack of access to healthcare or poor individual choices. They're mostly the result of policy decisions that systematically disadvantage some populations over others. And when you see a pattern that is by race, when you can see that systematic disadvantage is mostly affecting populations of color and American Indians and LGBTQ, low income, when there's a racialized pattern, that's actually shows us that we have structural racism. The reason I have this slide is that we can tell this story with our data. And often we've stopped at the first step of the data and have only told a story that we're having health differences. But that connection point where we describe the connection to the social determinants, including that in our data, is and then connecting those dots is necessary to be able to identify and lift up this connection between this and policy decisions. Next slide. So this is really, so if you think about just measuring health disparities, it would actually be in this box that's called health. We would be here, we'd say, here they are, here's our disparities, here's how bad we're doing, here's how well, who's thriving, we would just keep describing. And then the next step is this connecting to the living conditions. And that, is an important and critical step. But there's something even more in this, when we're looking at this broader pattern, there's something even more going on. So next slide. When we think about those living conditions or the social determinants of health, they're actually shaped by a set of forces beyond the control of the individual. Those include economics and the distribution of money, power, social policies, and politics at every level. That's global, national, state, local, and right within our very own organizations. Next slide. And in fact, we have socially created communities of opportunity where people have what they need to thrive and have good health status, and low opportunity communities where people don't have what they need to thrive and end up with worse or poor health status. And there is, again, a racialized pattern of the decision making in these spaces. So this brings me to the next slide. So next. This looking at this broader pattern helped me change my own practice. If we say our health is almost completely connected to our living conditions, we have to then also recognize that our ability to impact our living conditions, our capacity to act, is actually completely connected to our health as well. So our living conditions are completely interdependent upon our ability to impact the policy environment. Next. And the other word for capacity to act is actually power, and power just being able to do things. Next slide. So how do you build power? Community organizers would suggest that you can, well, not just suggest, they have a long history of doing this. We can organize people, organize resources, and organize narrative. And I want to talk a little bit about this. So organizing narrative is the one that I'm emphasizing right now, because it's not just narrative, but narrative sort of flows from our values and our worldview, but it's also informed by the data and the knowledge. And it isn't something that you do, you go away in a corner and you do it and you figure out the perfect narrative, or you have some sort of expert communications team. You actually can and need to build narrative with people. And that's where the opening quote about story, where the conversation about qualitative data and being in relationship with people who are experiencing the greatest health impact of the inequities in our social policies, that is part of organizing narrative. And that helps us strengthen people and relationships. And then resources is not just money, but it's also the way money and resources and decisions are made and the processes. So next slide. So this brings me back to that first slide about system transformation. We look at the pattern, the meaning of the pattern, and what is sustaining the pattern. So we've talked about the pattern of disparities. We've talked about the pattern of inequities with determinants of health. And we've now talked about the pattern with power, and who does and doesn't have the power to impact living conditions. Now we get to the now what part of it, and is what can we do to change the pattern? And this just gives me so much hope, because you can change the pattern in a system with 3 to 7 simple practices. You just apply them across all the levels of the system that you have any impact on. And we can use the 3 practices of organized people, organized resources, and organized narrative to change the pattern of power inequities. Go to the next slide. We used to walk around with the power triangle, and it wasn't as easy to talk to everybody, for example, the legislature, about it. So we began to talk about it this way. We have 3 practices. We expand the understanding of what creates health to include the opportunity for health. So the determinants and those connections. That's organizing narrative, data, and knowledge. And we strengthen the capacity of communities to create their own healthy futures. And that's where engaging people in the data collection and in the storytelling is also part of that process. And then we implement a health in all policies and places approach with equity as the aim. And these 3 practices are completely interconnected. Next slide. And then you apply them and you just keep doing them, and then you think about them. So the reason I think narrative is such a critical item is that, or practice, is that it shapes all the possibilities in the policy arena. So when public sentiment, this is Lincoln's quote, is everything. With public sentiment, nothing can fail, and without it, nothing can succeed. It makes statutes and decisions possible or impossible to be executed. So it's really, when my colleague said you should not go to a meeting with the community, unless it's everyone, and housing is not our swim lane, that is a narrative being reinforced within the department and within our public health field that was about what we were supposed to be doing, what our values are, what our understanding and belief is. And it was, and we're reinforcing it when we only collect data on cancer and heart disease and deficits. So we can change that narrative by collecting and sharing the broader story of what creates health. Next slide. We have a bunch of tools: data collection, assessments and analysis, reports and white papers, policy at all levels, health impacts assessments, convenings, and just plain old asking a set of, of appreciative inquiry kinds of questions. Next slide. So back to the story. So when my colleague said that to me, I could have waited and then had an argument with him, but that isn't a very systems-oriented approach. You have to think about what is holding the system in place. So when you look at that pattern, it's a set of beliefs and a set of sanctioned relationships. And so what I did was, the first thing, we had regular work, like doing the state health assessment and creating a Healthy Minnesota 2020 vision. And normally you bring a lot of smart people together and they give you input, and then you make a plan, and then that's your plan for the next 5 years. Then you bring people together and you do it again. But what we did was we reconfigured the group of people for what we call the Healthy Minnesota Partnership. And we began to look and change and expand the group of people from the typical people that we had from healthcare and public health and all the disease groups, and to expand to include faith-based organizers, union organizers, broad-based organizers, people who were working with and or organizing in particular communities experiencing the greatest health inequities. And then we also expanded the sectors and included public transport, included the Department of Transportation and Education and Corrections and Safety and Housing. And we developed a common analysis. We knew what would create health. That first slide that I showed you, and we were clear there, but we started to do our regular work of doing the state health assessment. And when we began, we started the same place everybody would start. How much cancer do we have? How much heart disease? Who's smoking? Who's not exercising? And at one moment, this group of people, so this is why relationship and the who you've convened and is so important. This group of people said, why are we measuring what happens when we don't have health? Why don't we measure health? And so our 2020, or our assessment that we conducted in 2012, we actually led with, here's who we are, here's how we're changing. And here is our data on who's graduating from high school, who owns homes, who has food security, who's incarcerated, who owns businesses, all of that. And then we put the diseases in the appendix so that we could make it even more clear that these diseases and or health outcomes were the result of the opportunities, the differences in opportunities. And this is what I mean by changing and organizing narrative and using your data in a different way. When we had brought that different set of people together, we had we had said everybody had to have people they were responsible to. They weren't about advising us. We were organizing together how we were going to move Minnesota in this direction. And so immediately this group was able to use this state health assessment to get funding from a health funder to run their campaign around criminal justice reform. And then a group of them came back to us and said, we're going to be working on a campaign to increase the state minimum wage. Can you write a report on income and health? We were able to do that. They used that report to and show who is and is not thriving and what the impact is of an increase. And they used that to change the debate around the state minimum wage and change it from being just stuck in the committee that was about being against businesses, that's not the real name of the committee, to expanding to the health committee and to a broader set of stakeholders and or policymakers, and they passed an increase in the state minimum wage. They then were so positive about that, they came back and asked us to do the same thing on paid leave. They used that paid leave report to advocate for ordinances to require paid leave in the cities of Minneapolis and St. Paul. And just yesterday, they had a packed hearing, even though it was 24 below zero, at the state legislature for a state paid leave initiative. And they lift up that data and those stories in those things. So this is about using our data to strengthen communities, using that relationship to strengthen the community's capacity to advocate for policy in a broader arena. Next slide. Next slide. we were able to move from that report to writing a report on advancing health equity in Minnesota. This report, we actually engaged 1,000 people helped write this report, and we were able to, in this process, have people, we named structural racism as actually one of the significant threats to the health of the state. Next slide. And then one of the things when you're doing system change, you can't just do things at one level. You have to have a strategy that strengthens people at every level in the system. So we also then created this health equity data analysis tool that helped us go forward. Next slide. Next slide. That actually helped us strengthen local public health's ability to do this. Next slide, please, Drew.
One second, Jean, I'm trying to figure out where that music is coming from. 1 second. If everyone can please mute their lines. I'm trying to mute people, but some of these, I'm unable to mute some folks. So I'll figure it out. Sorry about that, everyone.
That's okay.
It is very pleasant, though.
It is pleasant, you're right.
It's pleasant to talk about it. Next slide, Drew. And the next slide. So this is the health equity data analysis. By the way, I have a set of resources at the end of this PowerPoint that we want to look at that goes into more depth about some of those stories, and is, I think, could be quite helpful. And that HEDA, that we call it a HEDA, is in there. So in the health and all policies process, we use a set of questions, the data obviously, but these questions about who's benefiting, what health impact, and who is being impacted, whose values and beliefs and assumptions are leading. We have all sorts of assumptions and beliefs that we aren't transparent about. We don't even recognize them ourselves. And when we've begun to unpack those in our work setting and with our partners, we discover that we've made a bunch of assumptions that are so then the next part is there's a resource there at the bottom of this slide that actually brings you to a set of questions that we've used to disrupt our practices and examine these assumptions. Next slide. This is just what this looks like when you begin to change the pattern. So this is just sort of a timeline of the kinds of things that changed. And initially there was work on using, changing our state and federal transportation policy. I could tell a story about each one of these, but this is just, I mentioned already, paid leave, and we then have done work on incarceration and health. When I think about how we've gotten to the place where APHA just passed a thing saying that incarceration is a public health threat, from the point in time when my colleague is telling me I can't even go to a meeting on housing. That's a big shift in growth in the field in terms of owning the organizing of the narrative and really being able to tell the bigger story about health. Next slide. So data and measurement can transform systems by changing the patterns and expanding health. It is a way of strengthening the relationships and building community relationships, and actually the strength of the people who want to advocate, because we're telling the story. We're helping tell their story that they can then use to advocate for what, to create their own healthy communities. And it informs our work plans and changes our policy making. Next slide. The work is basically not necessarily new work, but it has to be interwoven with all of our other work. We have to recognize it's iterative. We have to be intentional about it. I have to say, it's this work to organize our data and narrative takes sort of a commitment from the organizations and our partners. We have to really reflect on what we're saying with what we're collecting and how we value what data we value. And that takes sort of like checking each other. When we were writing the report on income and health, we actually, on our last edit, recognized that we had written, if you have more money, you'd buy health insurance. And we went, well, that's not the point. I mean, it's maybe true, but it doesn't have to be the thing we're leading with. And so that's that, but it's a skill, a muscle. And the work is incomplete and it is imperfect. We have to give ourselves the permission to interrupt ourselves and recognize that it isn't about getting the right thing done right now, but it's about navigating forward toward health equity and making course corrections along the way. And that's consistent with what we mean when we say we're trying to change the pattern in a system. Next slide is the last slide. I love this. My commissioner used to use this all the time, but public health is the constant redefinition of the unacceptable. But that's it. The last slides are just for your reference. I didn't know how we did.
Oh, Jean, thank you so very much for this awesome presentation. So now we're going to open it up for questions. So if you have a question for Jean, feel free to chat in or just unmute yourself and ask your question.
We have hundreds of stories, so
Do you mind if I kick it off? I have one question, and then I can kick it off a little bit. So, Jean, is there any advice to the many health officials on the call right now of when you're talking about this engagement within the community, and you showed some great examples, and I know I will send some more. Any pitfalls or any things not to do? I know a lot of times we tend to go back to the same methods that tend not to work. If you have any advice on that.
One of the things is that it does, I think my first advice, I remember being in a meeting and someone said, when you meet with the community, you just have to meet with them. You shouldn't have an agenda. And my advice is that no, you should know what you're wanting to accomplish. You should be transparent about your values and your assumptions and willing to engage around your values and assumptions with whoever you're meeting with. When you're in a political role, you meet with people that you don't agree with often. You might meet with the beverage industry and, they're wanting to expand sugary beverages and they're worried about you doing something, or you'll meet with, anyway, you're meeting with a lot of groups. And I just think it's not about just being open. It's about being clear about why and your values and what you're trying to accomplish. And I believe that by leading with race and structural racism and health equity, that we're clear partners. That doesn't mean everybody likes it. But when some of my most fun has been to, we're a state with a large rural population with county commissioners, and we would meet regularly with the county commissioners. And when you first start having those conversations and talking about health equity and structural racism, they're not so sure that, people say, are you, something or other, so that's always one of the tensions. But when you actually sit down and you say, this is what we're trying to achieve, this is the data we're looking at, let's talk about our assumptions about what's creating it. I remember talking to a Rotary group in rural Minnesota, and I'd show them the data on infant mortality and they'd have an idea. They're sure it's because there's a bunch of teens who are having babies. And then you show them the data on diabetes and they have another personal responsibility story, and then you kind of go, but look at this pattern. Now let's talk about the pattern. What can this possibly mean other than we've got to begin to look at these at the way we're doing our policy making and assure opportunity. So being clear about who we are and what we're trying to achieve is, I think, my best advice, I guess.
Jean, I have a question. This is Romana. My question is, so a couple of things. So when you're sharing stories, how are you triangulating, and are you triangulating? And if so, how are you doing that to show there are many points with where this story is coming out in our data and our overall stories? And then when you're showing qualitative data, like when we were doing the journey mapping, how can you impose quantitative data on that effectively? So not only is it representing the communities, but when you're trying to get buy-in from funders, they can also see how valuable the stories are in their language.
Well, that's a really interesting. I'm not sure I know what you're meaning by the triangulating, but I can say that part of why I'm interested in qualitative data isn't just so that I can have better data with a story. It's because the relationship that's built when we are actually listening and incorporating people's experience into the data helps us to have more, like make a more clear path forward. So I have a lot of like examples. So there's an example of a rural community, and they were working on, and with that HEDA, what we did was we asked each of our grantees to find one health outcome and connect it to one social determinant, like just to begin to build their muscle. And to do that, they looked at the quantitative data and the information we have, but they then would connect with community groups and whoever they could reach, whoever they could convene, and again with a focus on group, not just like a town hall meeting. And it was interesting, like one community said, well, isn't it interesting, this is Minnesota, they were a Latino community in a rural area, and the town had enough money to keep the lights on the hockey rink at night, but not the soccer field. Mm. And then the story, when you start to show that, and then what does that mean about who's included and who's excluded, we don't become the storytellers. The story, we have now lifted up and connected with a group of people who can also advocate for what they need in partnership with us. So I'm not sure if the answer is, it's not strictly about incorporating someone's story into data as much as who's now the storytellers. Mm-hmm. When we were doing the health equity report, we had decided, because there were people who were very clear and in relationship with us, they said, you need to lead with race. And we had to deal with all the tension that creates within our agency and with partners, where people would say, well, yeah, it's race, but it's also income and it's geography and it's LGBTQ. And they had a very compelling reason. And it was, we have a sheet I could share on, our talking, like why we chose to lead with race. But when I was telling people we were going to be, that our report was going to end up coming out saying that structural racism was a health threat in the state, people said, you can't do that. The legislature's going to cut us off. That's not the role of a government agency. Somebody's mad, everybody's going to be mad. And I said, when we're done, it won't be our report. When we're done with that report, it'll be the community's report, because we engaged 100 people in the agency to write sections and to convene other people. And through that process, 1,000 people were bringing their stories. By the time that report was coming out, people were having press conferences that we didn't know. I had never met them. And they were telling the story, because sometimes I think it's just amazing the amount of positive attention we got for telling someone, for validating a story that was so clear and showed up in all of our patterns of all of our data. And yet, it did strengthen the whole effort in Minnesota in philanthropy and local public health. It allowed other people to advocate for what they needed. So I don't know if that completely answered your question, and I can brainstorm more with you about that.
Thank you, Jean.
Yes, thank you so much. And Jean, in the chat, there's a question from Preeti. Narratives and stories posted on the website. And then also a question, how did you get the programs to agree that their program is not listed in the priority?
Oh, are you talking about, it must be talking about the Healthy Minnesota? That was interesting. Sometimes when I have more time, I say, we decided to lead with opportunities, and then we put the diseases in the appendix. And actually, you're right. The first thing that happened was the people in the agency were sad. They were sad because they felt like the new administration must not care about their stroke program or their whatever they were used to being front and center in every state plan. And first of all, we didn't do it. The Healthy Minnesota Partnership did so it wasn't the administration. This was a partnership that ended up doing, and leading this way and helping guide it. But it was really great because over time, we then worked with people in the agency to be able to tell the story of their like if they were people working on diabetes, that they learned to tell that story in the context of the social determinants as well. So that we were building that muscle through the whole agency. It was only a couple years later that the people leading diabetes did a whole analysis of employment in diabetes. And looked at how people with diabetes are excluded from the work setting, and is it because of, and so they began to tell that story, and we tried to constantly be sure that we were reinforcing a broader understanding of what creates health, and having people recognize that their progress in the disease initiative that they were so committed to was also completely connected to understanding how certain groups were thriving and not thriving. So it ended up being an invitation for everyone to do that. But it takes a lot, and that's why I say you take a systems approach. It's not a program or a one-off. This is a direction and a commitment and a recognition of what really creates health. We can't minimize, and because you're looking at changing a pattern, you don't necessarily get 100% of everybody doing that. You're trying to strengthen the pattern and diminish the other pattern. But there are certain parts of the scientific, reinforcement system that keep people from going forward in that way, or not everybody goes there. What was that other question? Are the narratives? Yeah, so if you look at I have a bunch of stories that are connected at the end of the PowerPoint that I have links to, that have been written up. The Human Impact Partners folks wrote up the story on the broader, longer story of narrative, and I think there's a link in there also to a group of Berkeley students who wrote up a nice picture of a very nice web sort of thing. And then there's 2 stories in there about the health equity data guide that they recently came out with. So there's some links to that. And then the reports are all in there.
Yes, thank you so much, Jean. So yes, the slides have been sent out and shared with everyone, so you'll have access to all of those amazing stories. Well, also I want to go on to our next presenter now, but then there's also a question in the chat for you, Jean, about wanting to connect with you offline to just talk more. Kathy from Maine. And so sure. Seeing nodding yes, so we will definitely make the connection for you both. And thank you.
My email is in the end.
Great. Well, thank you so very much. The presentation was fantastic. Okay, so next up we have Victoria Hurtado with the Downtown Women's Center. She is the measurement and evaluation specialist there. And I also had the pleasure of knowing Victoria for a while now. She, them with LA, they are a part of the SCALE communities, the Regions of Solutions communities. And so we're really excited to hear their story and how they've been using measurement and data. So Victoria, I'll hand it over to you.
Next slide, please. So before I get into the specifics of our work, I wanted to take a moment to give some context about homelessness in Los Angeles. The 2018 Los Angeles Homeless revealed that more than experiencing homelessness, instability of people. This, which is where our organization is located, is the largest homeless enclave in the country. It spans a 55-block radius and has about 20,000 individuals sleeping on the streets on any night. Color, age proportionate are women. The Downtown Women's Center was founded in 1978 and has been the only resource in Los Angeles that is exclusively dedicated to serving the unique needs of homeless and very low Los Angeles rural community. Providing 119 permanent supportive housing units with case management services. Each resident has access to the individual support and services to thrive in permanent housing and work towards achieving their goals. We have a drop-in center, which is point of access for all of our services, a place where women can have some of the most basic needs met, including having 3 nutritious meals a day, access to clean bathrooms and showers, change of clothing, and a space to just rest and socialize with other women. Our clinical services include access to mental health practitioners, as well as a healthcare provider through our women's only health clinic. We have a partnership with a local, we have a partnership with a local FHHC. We provide care, STD, HIV testing, different screenings, vaccinations, mammograms, as well as self-assessments. And then lastly, our education and job training services, which also includes the social enterprise, are designed to meet the needs of women current needs, regardless of their background or level of experience. Next slide, please.
Victoria, really quick.
Yeah.
I may have to have you call back in. I think you're going in and out of the sound. Are you using your laptop or you're on your laptop computer?
I'm on my phone.
Okay. All right. Yeah, the sound is going just in and out a bit. If you might.
I try again. Is that okay?
Sure.
Okay. Just give me a second.
If you want, you could possibly call back in using the call-in number. Were you able to call in and then just kind of reference the slides from there? Or if you want, you can just talk about the Downtown Women's Center and some of your measurement accomplishments, and everyone already has copies of the slide they can reference. It's up to you. In the meantime, while we try to work out, because I think we really want you guys to hear this story of how a local organization is doing some fantastic work as we look, as we start to march towards our action labs and our sprints, and we're looking to partner with a lot of local organizations. They're doing great health and well-being work in the areas that we're looking to transform. I think the Downtown Women's Center is a shining example of that, especially how they use measurement and evaluation. But while we wait for Victoria for a little bit, does anyone have any kind of questions about where we are on our journey right now with this Stateswood solution that we can answer together? Any concerns, any updates that anyone may have at this time? I think that went off mute.
Here, I have a question.
Sure.
So we're, as we know where we are right now in this phase of Stateswood Solutions, where many of you are, or, have started to think about what are going to be the action steps that you're going to be taking over the next couple months. I wonder if someone would be willing to share, what your action steps are going to be over the next couple months that you're trying to achieve.
Shannon, Victoria is back on using her phone, but
Can you hear me now?
Yes.
Okay, so sorry.
no worries. That's a lot better. Do you still want me to present the slides, or are you just going to lecture?
I can just go ahead and lecture. That's fine.
Okay.
Okay. So the Downtown Women's Center, in collaboration with different community partners, which included folks from the healthcare sector, academia, homeless services, and policy world, formed a steering committee that would focus on improving the health of women living and receiving services in the Skid Row community of Los Angeles. And in an effort to improve the growing need to improve health outcomes for women experiencing homelessness, we recognize the saliency of co-designing our programming with individuals with lived experience. And so 3 women with lived experience of homelessness, one of whom is diabetic, served as members of the steering committee to better inform our practices. The members provided personal insight into the needs of the community, gaps of services, program development, and the best ways to engage other participants. They shared the challenges that they were experiencing when trying to improve their own health and healthcare. For example, they stated that many people who are homeless do not have access to refrigeration, both for medication like insulin, and to be able to store healthy perishable foods. They shared that many of the shelters do not allow guests to bring food, do not allow to bring their own food. And that most shelters and other places that provide meals do not provide healthy food options, leaving them frequently to go days without fruits or vegetables. They stated that women in the community want healthier, but they also need education regarding quantities, what quantities of food to eat, how to eat each food item, how each food item impacts their diabetes treatment and other prevention efforts. And then they also share that they don't feel safe safe in the community, which also impacts their ability to exercise outside. And so after having a better understanding of the barriers to, for example, diabetes treatment for this population, the our steering committee created and developed what we called the Women for Wellness program. And it was a 1-year diabetes prevention and management program intended to help our female participants reduce their risk for diabetes and to help patients properly manage their diabetes. In this 1-year program, patients received diabetes health education and monitored their blood pressure and BMI with staff. The program included monthly screenings and weight measurements, and additional programming included health education classes, nutritional counseling, support groups, peer support, fitness classes, and other health screenings. And then lastly, we also hosted a walking group focused on diabetes during the fall following the program, allowing women to engage in learning how to manage their health and participate in physical activity. And so out of the 50 participants in the 1-year program, 48% improved their body mass index totals from baseline, and 92% improved blood pressure from baseline. Out of the 34 participants who completed the A1C screening test, 44 reported an improvement from baseline. The percentage of overweight individuals decreased from 28% at baseline to 26% at the end of the program. However, the percentage of obese individuals increased from 50% at baseline to 56% at the end of the program. Additionally, during this program, the percentage of participants who were permanently housed increased from 32% to 44%. What we learned from this experience proved that it was really imperative that individuals with lived experience must be active participants in all the co-design, planning, and administering of programs, policy development, to ensure that the design elements reflect their current needs. I am complete.
All right. Thank you so much, Victoria. And I'm wondering if we could go forward, do a couple more slides to the Women for Wellness Impact slide.
Yeah.
That shows about the 100 Million Healthier Lives questionnaire.
Mm-hmm.
Okay, thank you, Drew.
One second. I am having just technical difficulties. One moment. Okay. Yeah, so as measured by the 100 Million Healthier Lives Adult Wellbeing Survey, after the end of 6 months, women's overall health, perception of health increased about 44%, and by the end of the year, that actually doubled.
Oh. Just fantastic, to see the improvements there and from suffering, how much it's reduced, and then how much thriving increased over that course of that time. So thank you so much, Victoria, for sharing the story of the Downtown Women's Center. And now we'll open it up for questions. Does anyone have a question for Victoria? Feel free to chat in or unmute and ask your question.
So I see there's one in the chat. How many women were involved? For this program in particular, it was 50.
Victoria, you said 68?
50, I'm sorry, 50.
50, okay.
Yeah.
Nice. Amazing results. And it shows how, with some of the different measurement and data tools, it really is this tool, the common questionnaire that they used at Downtown Women's Center, is an awesome tool to use to show the results of your work in a very short time frame. So definitely amazing.
It is. And I think it's the adult wellbeing survey that's embedded into our Measure Matters platform. I believe, right, Victoria?
Wait, can you say that again? I'm sorry.
This particular well-being survey is the one that's already embedded into the 100 Million Healthier Lives Measure What Matters platform.
Correct.
Right.
Correct. Yeah. Mm-hmm.
Yeah. It is. So any other questions that anyone has for Victoria? Okay, great.
Question for her, Shannon.
Okay.
Victoria, your work is amazing. It's so impressive that you were able to help these women in a small amount of time. What were you, I know this is a very broad question, but what were you doing that was so effective? Like, what were the key takeaways that you would say you were doing to really get the effect that you did?
Yes, and that's a really great question, and that was actually part of some of the earlier slides. So I'm sorry I didn't get a chance to go over them. But one thing that that our organization has been really intentional about for the last year is putting into practice trauma-informed care. And it's a service approach which acknowledges the widespread and long-term impacts of trauma. And part of that is understanding signs and symptoms of trauma and responding, and by integrating knowledge about that into all our different programs and practices. And so it really, simply put, like, trauma-informed care as a method it recognizes this paradigm shift where we ask an individual what happened to you rather than like what's wrong with you. And so that's really where the healing process and trust starts to begin, and when reparative relationships are formed. A lot of the principles of trauma-informed care are key characterizations of helping relationships that really bring like a strength of character to our work every day to help build that trust. And in that process, we're conveying that, we have the strength to listen to their story. We're starting to build a healthy relationship. On the flip side, the participants that we're working with, are really trying to figure out if we're going to judge them. Most of them have been let down by the same systems or service providers that they seek or go to for help. And it really, does contribute to those negative feelings. And so we just recognize the saliency that trust increases the likelihood of better outcomes. So that's kind of the lens that we've taken and we've approached.
Thank you.
Great. And Victoria, there's also a question in the chat from Kathy. How were you funded?
We were funded from individual donors, corporate foundations, private foundations, as well as federal, so government. So it's a wide range.
Thank you.
So forgive me for this really silly question, but since we talked about movies earlier, how many Hollywood movie stars have stopped by the Downtown Women's Center to volunteer?
Well, that's so funny. We have just yesterday, James Franco came by. He's been coming like 2-3 times a month for the past 3 months. But we've seen David Arquette, Demi Lovato, one of the girls from 90210. Her name is escaping me for the moment. So yeah, we get some celebrities every now and then.
That's very similar to Kathy from Maine. She gets a lot of Hollywood stars to come through Maine as too. So you guys have something similar in common.
Oh, that's great. So, okay, well, it is survey time, everybody. So Drew chatted in the link to the survey. So please, we you all to just take a few minutes right now, not even a few minutes, 60 seconds right now. So we're going to pause, and the link Drew has chatted it in again, so let's pause for a second. Please take the survey, give us your feedback on the call today, and then we'll come back. So I'm gonna start my little timer now. All right, everybody, feel free, if you're still working on your survey, feel free to continue doing that. And so now, Drew, can you go to the next slide? We're gonna just enter into it for our last 15 minutes on the call. Feel free to share any questions that you have. Ask Steve, what offers would you like to make to the group?
Shannon, it's Victoria. Can I add one last thing?
Sure.
Okay. So on the last slide I had, I was going to talk about some areas for growth. And so, you know, our organization, we spent a couple of years, you know, we've been starting the process of trying to engage, you know, individuals with lived experience. And we recognize there are many nuances when it comes to that. And we're definitely not without our fail forward moments. And, you know, there are, you know, some of the areas for growth for us, and, you know, it's kind of like putting out best practices out there. The first is, you know, when working with individuals with lived experience, it's really important to understand that they might also have conflicting priorities. So it's important to have, you know, just reasonable expectations of like their participation and engagement. Like I know for us, some of the women we work with are still looking for housing, might be unemployed, or are balancing different chronic health conditions. So it's just really important to be mindful of that. And then also there's likely a history of trauma, and it isn't unlikely that, you know, in the co-design process that participants will be, you know, might be triggered. So it's important to be mindful and, you know, creating that trusting and safe space, but also following up to see if any additional support is needed. And then lastly, you know, this is something that we're beginning to explore, but like providing some sort of compensation for individuals with lived experience, because like any other, you know, like we compensate other consultants, we compensate consultants for their expertise, and we need to do right by, you know, providing some sort of, you know, incentive or, you know, compensation for their participation. And so I just wanted to throw that out there.
Thank you so much for sharing that. Yes, that all such great points. Such great points.
That's an interesting point, Romana, about ACE. And I know our friends from Maine have been doing a lot with adverse childhood experiences also. So, is that a question, Romana?
No, it was just a thought while Victoria was talking. Seems like it would fit together. Yeah, it was just a thought I put in there. Thanks.
So what questions do you have? Do you all have any questions of us, or what's circling around for you, or is there anything that you'd like to offer or share with the group? Okay. Well, if there aren't any more questions, just update the next call that we have. I'm really excited for this one. We're partnering with the 100 Million Healthier Lives monthly momentum call, and we have Dr. Tiffany Manuel, who's going to do a presentation on making the case for equity. I don't know if any of you have heard of her. I have heard her speak before, but I had a chance to hear her back last September, and she is amazing. So we're really excited about this call. It's coming up Thursday, February 7th from 3 to 4 p.m. And then she'll also be holding a set of office hours on February 12th. So you all will get those calendar invites, and we're really looking forward to that call and hope you all can join us. So that brings us to the end. If no one else asks any more questions, you can get 10 minutes back in your day. All right. Well, as always, we're here. If you have any questions or need support, reach out to us. We're here to support you and hope you all have a great rest of your day. Bye.